Hi, everyone. My name is Michal Lightman, and I will be moderating tonight's event. I graduated from Stern College this past May as a biology major, as well as being on the pre-med track. I'm currently taking a gap year while applying to medical school this year, and will be working at Reproductive Medicine Associates of New York as a fertility care coordinator. I'm also a member of the JOWMA Women's Health Committee, and we thank you all for registering for our webinar about the fourth trimester. Tonight, we plan to address topics including postpartum depression and anxiety, breastfeeding basics, formula versus breast milk, complications of breastfeeding, and when to see a professional. There will also be a Q&A at the end of the event. Please keep questions broad. All questions should be posted in the question box. When asking questions, please hit the Remain Anonymous button. Your presence on this webinar is completely anonymous. Your video and voice are not enabled, and attendees cannot be viewed. So first, we're going to be starting with Dr. Lauren Macaluso. Dr. Lauren Macaluso provides specialized medical care for breastfeeding mothers and their children at her office in New Hyde Park in Nassau County. She's a partner in Allied Physicians Group. She is proud to have a medical practice where lactating parents can get their and their baby's needs met in one place. She's a fellow of the Academy of Breastfeeding Medicine, fellow of the American Academy of Pediatrics, and co-breastfeeding coordinator of the New York American Academy of Pediatrics chapter covering Long Island, Queens, and Brooklyn. She received her Bachelor of Science from Cornell University, her medical degree from Sidney Kimmel Medical College of Thomas Jefferson University in Philadelphia, and completed her pediatric residency at Children's National Medical Center of George Washington University in Washington, D.C. Dr. Macaluso's special interest in breastfeeding started after nursing her own 2 children while working part-time with medical students and residents in the newborn nursery. She identified a need for breastfeeding-focused care and started her practice in 2006. She shares office space with her neurologist husband and takes pride in their teamwork to help others. She was an all Ivy League field hockey player at Cornell and continues to focus on fitness and nutrition. So we invite Dr. Lauren Macaluso to begin speaking.
Thank you. Hi, everybody. It's a pleasure to be here with you. I'm speaking on a number of breastfeeding topics tonight, and for time's sake, I aim to touch upon each with time for questions at the end. In recognition of language being as inclusive as possible when discussing infant feeding, it's important with individual families to use language they identify and are comfortable with. For the sake of tonight's group experience, I'm using the traditional terms breastfeeding and moms. First slide, please. The fourth trimester is a unique and transformative time. During the 12 weeks following delivery, moms are recovering from childbirth mentally and physically. They're adapting to their changing body, hormones, body image, and role, learning to feed and care for their newborn, and adjusting their relationship with their partner, other children, family, friends, the workplace, and society as a whole. Mental health is tremendously important during this time. It's important for those of us interacting with new parents and families, such as breastfeeding medicine physicians, OBGYNs, pediatric and family practice physicians, to have an understanding, awareness, ability to screen, refer, and provide resources appropriately. There's a disease spectrum with many parents experiencing mood changes during and after birth. The postpartum blues are when a patient experiences emotional changes, insomnia, appetite loss, and feeling overwhelmed. They affect 30 to 80% of women, peak day 5 and resolve day 10. Close follow-up is recommended to make sure they are resolving. Next slide. 15 to 20% of women have more significant diagnoses of depression or anxiety. They can appear anytime during pregnancy and the first 12 months after delivery. They include depression, anxiety, panic disorder, obsessive compulsive disorder, post-traumatic stress disorder, bipolar mood disorders, and postpartum psychosis. For the sake of time, I won't go over the history and symptoms of each diagnosis on the spectrum, but further information can be found at Postpartum Support International at postpartum.net. Next slide. Per the Academy of Breastfeeding Medicine's use of antidepressants in breastfeeding mothers protocol, pediatricians can screen for PMADs at the 1, 2, 4, and 6-month well-child check visits. OBGYNs can screen at the C-section incision check at 2 weeks if that applies, and at the postpartum visit at 4 to 8 weeks. ACOG, the American College of Obstetrics and Gynecology, recommends that all women have contact with their provider within the first 3 weeks with ongoing care as needed. We should be referring if screening is positive. And in terms of screens, the Edinburgh Postnatal Depression Scale, very much known as the EPDS, is commonly used. It's a 10-question screening tool to identify if a patient is at risk for perinatal depression. The General Anxiety Disorder 7, or known as the GAD-7, is a 7-question screening tool to identify a clinically significant anxiety disorder. Next slide. For resources and referrals in my New York area, I realize not all of you are probably in my locality, but I'm hoping that you will be able to find resources in your own communities. Here in New York, we have a wonderful resource on Long Island. It's the Postpartum Resource Center of New York, and it can be found at postpartumny.org. They have a statewide helpline and provide educational information and links to support groups and healthcare resources. Another important local referral source in my area is the Perinatal Psychiatry Services at Sucker Hillside Hospital, and they provide insurance-covered outpatient and inpatient care in my community. Next slide. Treatment approaches can be non-pharmacological, pharmacological, or both. For non-pharmacological treatment, that's psychological therapy. It's first line for mild to moderate symptoms. Patients are monitored and reevaluated, and if they're not improving or worsening, it's recommended to consider pharmacological treatment. Pharmacological treatment is second line for mild to moderate symptoms. For moderate to severe symptoms, it may be the only thing that's needed. I'll see moms in my practice add on medication if they're not having improvement with therapy only, and others who do really well with just medication. Combination therapy is for moderate to severe symptoms, or if a patient has current stressors, interpersonal issues that psychological therapy can address. Examples in practice that I've seen are a parent death coinciding with a mother giving birth, or a partner with a cancer diagnosis that mom's trying to work through as well. I apologize, my screen just kind of freaked out a little bit. So I'm just going to click on the Q&A and that kind of, hang on one second. I apologize for one sec. Here I go. I'm going to go to the next slide, please. In caring for patients, we want to include a discussion of their breastfeeding experience. Breastfeeding may enhance bonding, improve mood, or it can also be really difficult for moms. In practice, some moms state that their breastfeeding challenges are exacerbating their anxiety or depression. So you want to consider simplifying their feeding plans. You want to be aware of what's known as triple feeding, where they're latching and pumping and supplementing. It can get really overwhelming for them, and it's important for mom and baby to have time to enjoy each other. Nighttime demands can be really challenging, and a lack of sleep may be a major trigger for mood symptoms. It may be helpful to allow a mom to have a 5 to 6 hour sleep span at night. Then another caregiver can feed or bring the baby to mom to feed at the breast and do as much as possible of the additional home responsibilities as well. I personally like to describe moms as exotic plants that need to be watered and fed and receive a lot of TLC as they're working through this really challenging time in their life. Next slide, please. Medications are approached with an informed clinical approach. Previous treatments, targeted symptoms, family history, experiences with medications, current and past medical disorders, current medications, allergies, side effects of the medications, and maternal choice should all be taken into account. You want to use an individual risk-benefit analysis. If there's no history of antidepressant treatment, then sertraline is considered first choice. It has the best safety profile during lactation and lower levels in human milk and infant serum, and there's few side effects. The recommendation is 25 milligrams for 5 to 7 days, and then increasing to 50 milligrams per day. Patients are often followed by psychiatry as well. If a patient was successfully treated with another medication in the past, the recommendation is to review the data, and you can consider that medication first line as long as there are no contraindications to breastfeeding. LactMed and Infant Risk are evidence-based resources for medications in pregnancy and lactation that we can use as we look these medications up. Take homes to share with mom to help her feel comfortable with the medication start. Our exposure of medication in breast milk is less than during pregnancy. Treatment of a mood disorder is critical for the health of mom and baby, and reminding her that many mothers experience this and it will be okay. Next slide, please. So when I was asked to speak about formula versus breastfeeding, my first thought was an equation of formula versus breastfeeding equals support. I feel it's important to point out that it's not, you don't want to look at it as one against the other. The goal really is universal evidence-based education and support for infant feeding. Breastfeeding is normal. It's what we were meant to do. It's optimal for maternal and child health. Feeding is standard. Every child should get enough food to grow and thrive. Formula is indicated by informed choice, an infant medical condition, or a parent unable to breastfeed or with low production. The goal is informed decision-making that is evidence-based and includes holding support for the lactating parent, baby, and family. If mother's own milk through latching and expressing don't meet infant requirements, then supplementation with safe donor milk, and if not available, then formula is recommended. And noted for the preterm, very low birth weight infant, late preterm infant born at 34 to 36 weeks gestation, and the early term infant, 37 to 38 weeks infant in the most recent AAP policy statement. All real global societies that interact with moms and babies have policies. The US Surgeon General, the US Department of Health and Human Services Office on Women's Health, the CDC, the AAP, American Academy of Family Practice, ACOG, and Academy of Breastfeeding Medicine all have policy position statements citing researched risk reduction and health benefits of breastfeeding for mothers and infants. And the AAP policy was just updated 2 to 3 weeks ago. Next slide, please. Underproduction or slow weight gain. Normal weight loss in term breastfed newborns averages 6 to 7% of birth weight by day 2 and 7 to 8% by day 3. The goal is an individual mom and baby dyad approach, as we can see weight loss reaching 10% even day 3. And often you can see then on day 3 milk supply increasing rapidly. There can be others where supplementation is needed as this change isn't happening as well. You really want to consider mom and baby factors such as maternal intrapartum IV fluids, birth trauma, C-section delivery, a delay in lactogenesis for mom, maternal illness, insufficient glandular tissue, infant sleepiness, timing of first feed, and neonatal jaundice. A medical indication for supplementation is determined after full evaluation of mom and baby with hands-on observation and assistance with latch, a test weigh, and evaluation of expression as well. Next slide. In the mom-baby evaluation, we're really doing detective work to figure out, does the mom have low production? Is the milk not being transferred well to the baby? And or is the baby not able to feed well or grow normally? And this can be really challenging. Moms can have low production from hypoplasia, also known as insufficient glandular tissue or IGT, a history of breast surgery, retained placenta, thyroid like postpartum thyroiditis, pituitary issues, prolactinoma, a theca-lutein cyst that usually secretes testosterone, medications that can impact milk production, and supplements. Mom to baby low milk transfer can happen with one-sided feeding, spacing of feeding, sleep training, expressing milk and storing it, and something we like to call in the field oro-nipple disproportion. Sometimes a mom's nipple is just way too wide, long, big for that baby to climb the mountain and get on deeply and transfer. And nipple shield use can impact transfer as well. Babies can be premature, small for gestational age, sleepy, have ankyloglossia, oral motor dysfunction, gastroesophageal reflux, allergy, GI structural abnormalities like pyloric stenosis, or cardiac abnormalities like congenital heart disease that can impact feeding and the ability to transfer milk and grow. Now we're going to change gears over to overproduction on the next slide, also known as oversupply or hyperlactation. It's usually described as primary, which can be idiopathic. It's just that some moms can really produce milk incredibly well. We like to say they would probably be the wet nurses of our generation. Or it can be secondary, which can be self-induced, where a mom excessively pumps, as an example, or iatrogenic, where we tell her to pump or tell her to do things that are going to really exacerbate milk production. And then we're not always great about telling a mom, monitoring production and telling her when to slow things down and stop the additional pumping. You want to recognize it as it presents usually with persistent breast fullness, pain, leakage, plugged ducts, mastitis, a baby with rapid weight gain. The typical weight gain for a term newborn is 1 ounce a day. A lot of times these kids are growing more like 2 ounces a day. They can be choking and coughing with latch, clamping down on the nipple with really strong flow and letdown. Feeds can be really short. They can be spitty and refluxy and have explosive poops. By guiding and supporting a mom, you can help prevent this and to calm her overproduction by recognizing engorgement and inflammation, helping her to avoid overexpressing, like using a silicone hand pump on the opposite side during latch, avoiding pumping to empty during expressing, and trying really hard not to express more than your baby needs, and addressing anxiety around and need to store and potentially fill a deep freezer and overwhelm her body with overproduction. The goal is to teach moms to use their normal feedback loop with a gradual reduction of additional expression, expressing to soften, not to empty when she has overdistension, pumping what the infant takes when she's separated, and the goal being normal physiologic breastfeeding. We can utilize herbs and medications if needed. We will go to sage, peppermint as herbs, pseudoephedrine, a combined oral contraceptive if a mom is greater than 6 weeks postpartum, or if she's, more than stronger supply and is having a really, really hard time bringing it down, we can go to cabergoline. These are patients that are high risk for the mastitis spectrum. And I really want to encourage you all to check out the new mastitis spectrum protocol that just came out from the Academy of Breastfeeding Medicine as well. It's really helpful to understand the further pathophysiology and treatment recommendations. That's hard to find the time to do here. Next slide. I'm going to quickly go over kind of this mastitis spectrum as was asked to do. Plugged ducts are microscopic ductal inflammation and narrowing, and they present as an indurated area or tender congested tissue. Excessive emptying exacerbates plugging. And the goal, again, is to help these patients to get to normal physiologic breastfeeding. They can feed the less congested breast first to avoid overstimulation if needed. Anti-inflammatory support is the key for these patients with ice, ibuprofen. You can additionally use acetaminophen for pain, and you can consider using lecithin as it has anti-inflammatory properties as well. You really want to teach these patients to avoid aggressive massage as this can damage tissue. Next slide, please. Mastitis can be inflammatory or bacterial. Inflammatory mastitis is persistent worsening ductal narrowing, and the surrounding inflammation progresses. It presents as an erythematous, edematous, painful region, can have fever, chills, and tachycardia. A lot of us, I think we're always taught when we hear a mom that has fever, chills, erythematous area of the breast, we've been really in the past taught to think this mom definitely needs antibiotics. But we're finding that you can have these symptoms and infection is not always present. Next slide, please. Bacterial mastitis is truly an area of cellulitis with worsening erythema and induration. You really want to see cellulitis and induration to consider antibiotics, and this is where they're indicated. Many cases are inflammatory, as I said, and they can respond to anti-inflammatory care, especially that ice and ibuprofen and the calming of a mom's oversupply. If antibiotics are indicated, dicloxacillin is first line, clindamycin or trimethoprim sulfamethoxazole are second line. There's no risk to the infant when mom's taking antibiotics, and there's no recommendation to interrupt breastfeeding. Next slide, please. A galactofeel is ductal narrowing that obstructs milk flow, and it collects in a cyst-like cavity. They range in size from small of 1 to 2 centimeters to very large, greater than 10 centimeters. They usually present as a firm mass. They can increase in size over time. They can fluctuate, and they can be uncomfortable. They're usually not as bad as an abscess and usually don't have erythema or systemic symptoms unless they become infected. An ultrasound is indicated to diagnose and shows a cystic fluid collection, and image-guided aspiration can be used to confirm diagnosis if needed. Drainage is indicated if they're symptomatic for symptom relief or to facilitate latch, and a breast surgeon may choose to do a drain placement versus an aspiration, as we're finding that typically and not infrequently, you need to do repeated aspirations. And a lot of times it's easier to insert a drain and get it done with a drain in place for a few days versus putting a mother through repeated aspirations. And these, as we said, can possibly convert to an infection as well. Next slide, please. I'm trying really hard to keep to my 25 minutes. I think I'm almost there. I was asked to speak about thrush, but as we're finding clinically in breastfeeding medicine practice, it's often not yeast. I think there's another great article. Please check out this retrospective cohort study that reflects what we're really seeing in clinical practice that was in breastfeeding medicine in 2021. I regularly receive consults of patients being treated with antifungal medications for nipple areola complex and deep breast pain with no improvement. The most common cause of pain in this area, most common cause is improper latch and positioning, often related to engorgement and a lack of education and support. There's a wide differential diagnosis for these symptoms, with symptoms of pain, erythema, and often pruritus. Many present failing antifungal topical and oral medications. Some have temporary relief, and usually that's secondary to the anti-inflammatory properties that antifungals also have. Milk cultures and biopsies are not confirming Candida, and Candida of the breast is most often seen in the inframammary folds or axilla, in places where, as they like to say, the sun doesn't shine. It's much more common to have fungus occur in those places versus the nipple areola complex. Next slide, please. You really want to consider a differential diagnosis. For time's sake, I'm not going to go over all the clinical factors of each of these presentations, but all of these are common scenarios that we see in a breastfeeding medicine clinical practice. When patients come in saying, I think I have a yeast infection, it usually ends up being one of these. And those can be subacute mastitis, a nipple bleb, dermatitis, vasospasm, a milk crust that usually accompanies exclusive pumping, hyperlactation. Once again, that state of overproduction can really lead to a lot of pathology, and postpartum depression. Next slide, please. These patients need a full evaluation with a history and physical, assessment of latch and positioning, and working through potential etiologies. Once again, a lot of our practice is detective work because you're dealing with a mom and baby, and it's not always easy to get to the cause of what's going on, but you really want to look for things like engorgement, signs of overproduction, pumping. Is that what's causing, this milk crust? History of eczema or psoriasis, more likely you can see eczema on the nipple areola complex. Allergens like nipple creams, breast pads, nursing bras, detergents, those can be seen with a contact dermatitis. Topical medications, pump parts, and the infant's mouth can all lead to that diagnosis too. Okay, I think I'm good. That was a lot to cover. I'm going to hand it over to Tamari, and we'll try to answer the questions at the end. Thanks.
Okay, thank you so much, Dr. Macaluso. That was really interesting and very informative. And now we are going to hear from Tamari Jacob. So a little bit about Tamari first. Tamari Jacob is a lactation counselor specializing in pumping for both exclusive and nursing mothers. After not having the support she needed to nurse her oldest son, she chose to exclusively pump. Her dream was to provide her son with breast milk, and this was the only way that was possible to do so. Realizing how little support she had while pumping and how little information was out there, she decided to create One with the Pump to provide all moms with help on their pumping journey. She exclusively pumped for 2 of her children and is currently nursing her baby boy with occasional pumping when needed. She absolutely loves supporting other mamas and steering them on a path that's right for them. Pumping does not need to be a guessing game. Together, her goal is to create concrete plans to help you feel in control of your journey. So we invite Tamari to begin speaking.
Hello, everyone. I'm going to make sure I have my slides. My name is Tamari from One with the Pump. Thank you guys for having me. I'm so happy to be here. You did the whole introduction, so I don't have to do this. I'm just going to get straight into it. I am very big on pumping because with my oldest son, I had no other choice but to pump. So I had to learn really quick and fast how to do that. And the biggest thing that I knew, this was in 2017, was that there was at the time basically no information on pumping at all. There was really nothing out there. I went to very, very professional lactation consultants, all over the internet. There really wasn't anything there. So my goal is to let you know, as either a first-time mom or a fifth-time mom, but someone who is entering their 4th trimester, just to know, I want you guys to know what you should be aware of. So let's start with the first slide. So starting off your journey successfully, what do you need to know? The problem with, I don't want to say the problem, the challenge, let's be more positive, with first-time moms, but sometimes even 3rd or 4th-time moms, is that you don't know what you don't know. So you don't know what, like, in what direction to have your journey. So tonight, let's talk about ways to start off before the baby's even born with being successful, so that you don't have to get to a point where you are already experiencing postpartum depression and anxiety, where you're already completely overwhelmed and have no idea what to do, where you're already like, what is this, baby? What is happening here? Let's give you the information beforehand so that you don't have to find someone in an absolute panic and you don't actually know even where to turn. Next slide, please. So the first thing that I have found that was the challenge was that the way that people look at breastfeeding. Now, when I say breastfeeding, I am referring to pumping or nursing, but you know, in the outside, not One with the Pump world, breastfeeding really, most people refer to it when you're talking about nursing. So when people say like their goal is to nurse, all they want to do is nurse, they really want to do it, in their head, or what other people will say is like, it's so natural. It's the natural thing. Everyone can do it. Now, it absolutely is natural, but just because it's natural doesn't mean that everyone can do it. I always think back to my 4-year-old son, to his journey. And I was like, well, if we were living like thousands of years ago, like, I don't know what would have happened to him, because like he absolutely could not latch. So what was supposed to be natural, like we would not have been able to figure it out. And I had plenty of milk. I just couldn't get it into his body. So I always think like, you know, you think it's so natural, you think it's this natural thing, but it really takes work and it really takes education to be able to do it. It's not something that you should just say, oh, it's so natural, the baby will just like magically latch and everything will be perfect. That is the first challenge, that if that is your mindset, you're almost, and I hope that that is what happens for you. I really, really hope that that's what happens for you. But more often than that, that is not always what happens. And when it does, I want to make sure that you guys know that you are not alone, that you're not the first or only person that feels like it's so natural. Everyone's been doing this for thousands of years. Why can't my baby do this? What's wrong with me? What's wrong with my baby? There is nothing wrong with you or your baby. It's just, that's why there are professionals, because we are able to help you, and you are a professional in some other thing, maybe being whoever you are, and let the people that are professionals in this lactation field help you in what you need. Next slide, please. So let's get educated. How and when to educate. the best thing that you can do for yourself, if you are still pregnant, if you're not, don't worry, you're still doing amazing. But if you are pregnant and you are planning, the best thing that you can do for yourself is get yourself some sort of prenatal education. That is a prenatal class, a prenatal session with a lactation consultant. You have to find someone that you connect with, that you feel like you like the way that they speak, you like the way that they talk, you like and you feel like you understand what they're saying, and you want to talk to them about what your plan should be. If you go into the delivery room and your plan is like, let's see what happens, I'm not saying, like, I really hope that it goes well for you, but I would really rather you not do that, so you don't let yourself get to a point where you're like, oh my God, what am I doing? So get prenatal education beforehand. There are plenty of people on the internet that you can find on Instagram. I offer one. There's plenty of other people. Like, find who you connect with and get a prenatal class or a prenatal session so you can understand, so you can tell someone what your goals are. Some people come to me and they say from day one, I want to exclusively pump. I want it from day one. I don't even want to try latching in the hospital. And in that situation, we will start from day one. What should you do? This is how you're going to start. This is how you're going to start pumping in the hospital. You need to bring this to the hospital. You need to have that. I'll give them all that information. For people that want to nurse before, you need to know it doesn't hurt. It's only helpful for you to hear what are the positions, what are the name of these positions. You know, the lactation consultant at the hospital will sometimes come in and be like, oh, you should try football. And I'm like, does anyone have one? No one understands what that means. If you're a first-time mom, you might not understand what football position is, which basically means that you're holding the baby over here. I should have brought a little doll, but that's basically what it is. That you should get some sort of education beforehand, and don't make this a guessing game for yourself. Don't be like, oh, let's see what happens. I will never forget, my son was maybe 2 days old. We were going to his pediatrician appointment, the one that you go to like right after the hospital. So he must have been like 48 hours old. He absolutely would not latch. I had no idea what I was doing to even get him to latch, but I couldn't get him to latch. He was screaming. I knew that I had milk. So while there's absolutely nothing wrong with formula, my goal was to give him breast milk. And I also felt, I mean, at that time, I didn't really know what it meant to like have a lot of breast milk, but now I know that at that time I had a lot of breast milk, so I wanted to give it to him. My mom and I was at our house. We opened this pump that I had never opened before. Nothing was sterilized. Like, the parts were straight from the factory. I picked them up and I was like, I had no idea. It was a Spectra pump. So if any of you guys have ever seen it before, like, it's a fantastic pump, but it has 1 million parts. And if you don't know what it is, it's like you're trying to put it together. We had no idea what we were doing. I would like put the pump on, pump for a minute and a half, take the bottle off, give it to my mother. She would have put a nipple on it while I was putting another bottle on. Chaos, absolute pure chaos that I really didn't have to go through. And the level of stress that I had that day was just, it was unnecessary. So I would like for you to not have to deal with that level of stress. You're still going to be stressed out. You are still going to be like, what is this life? What is happening? But I promise you that if you have some sort of idea of what you are supposed to be doing, your stress level will be down. I don't want to say significantly, but it definitely will go down. So I'm very passionate about this. If you guys cannot tell, that I really want you to get some prenatal education from me, from anyone, from the fine doctor we have on here. I don't know if you do prenatal education, but she does. Find someone. I personally don't do latching, so definitely don't come to me for that. But like, find someone that you connect with and get education. Next slide, please. Okay, so here's what I said before when I said that sometimes we don't even know what we are supposed to know. So as a first-time mom or as a third-time mom who had never been, like, let's say you're a third-time mom, if you've never been successful with breastfeeding, you're not going to have another baby and suddenly know what to do if you haven't done anything different. Something that I tell my followers on Instagram, something that I tell my clients all the time is that if you want something different, you need to do something different to make it happen, right? You can't have a terrible breastfeeding journey and then have another baby and be like, hopefully this one goes well. That is exactly what I did with my daughter. So I had my 4-year-old, I have my 4-year-old, but I had him. I don't want to say I had a terrible experience because it ended up being exactly what it was supposed to be. I ended up exclusively pumping with him for 10 months. And it worked out beautifully the way that it should have at that time. I got pregnant with my daughter and I was like, oh my God, like I'm hoping I would like lay awake at night wondering if I could nurse her. And then she was born, but I literally did absolutely nothing to make a difference. So again, and she was born March 2020. So she was born. I was leaving the hospital as the first case of COVID came in. So I left the hospital and the entire world shut down. So there, and in March 2020, I don't know how much we remember of that time, nothing was virtual yet because the world had just shut down. Now this is so simple, everyone come on Zoom. It wasn't like that then. My entire practice is virtual, but it wasn't like that at the time. So I had no one again. And again, I had no idea what I was doing. And I didn't know what information I was even missing to try looking for at places. So I ended up exclusively pumping again, which again, you know, plans come, God has his plan. One with the pump was born, and I could not be happier that it happened this way, but this is why it happened, because again, I had no idea what to do. So now with my third child, I was like, something different is happening this time, but I want to make sure that I knew and that I tell other moms what it is that they need to know. So I went like a little above and beyond, and I literally became a lactation counselor to figure out how to nurse my son. So like, you don't have to be that extra if that's not what you're feeling, but I was like clearly super passionate about it. And I wanted to make sure that I knew everything. So I took a course, I became a lactation counselor, which by the way, my course had absolutely, I would say 3 minutes of pumping education anyways. So that is why I created One with the Pump, to let you guys know what it is that you need to know. So the point of this whole background of this slide is, what do you need to know to be successful pumping or nursing, but sometimes pumping? So I talk to a lot of moms. Most of the moms that I talk to pump at least sometimes, because if you're never pumping, you're probably not going to come to One with the Pump. But so most of the moms that I talk to either exclusively pump, or they nurse, but they pump either occasionally or they pump at work, and they don't even know what they're missing. So let's talk about what you're missing. Number one is your schedule. Whether you are pumping or nursing, you need to know when to do it. It's a little easier when you're nursing because the baby's crying. So this is probably the time that I should probably start nursing. Not everyone actually realizes that. Being a first-time mom, it's incredible what we don't know, but schedules when you're nursing is a little bit easier. When you are pumping, you need to know when it is that you need to pump. When I'm having a consult with a mom, I'll be like, so I know you're I know you're 2 weeks postpartum, and I'll be like, when is it in your brain that you're like, it's time to pump? That's how I'll ask the question. And then they're kind of like, when the baby's eating, that's an answer I get. Sometimes I'll get every 5 hours. Sometimes I'll get every 2 hours, whatever it is. Like, I want to make sure that you know when it is that you need to pump. How do you know your schedule? That's completely based on you individually. So that'll be based on whether you're pumping or nursing. That'll be based on what your goals are. That'll be based on how much milk you make. Yes, if you are an oversupplier, you will probably maybe have to pump less amount of times. If you're an exclusive pumper, if you're a nurser, everything needs to be according to the baby. But you have to know your schedule, and you have to know exactly when it is you have to be emptying. The next thing that you need to know is you need to know your flange size. A flange. This piece is a flange. A lot of times it comes either totally connected to a piece or it comes separately. Big news, these come in sizes. I cannot tell you how many people don't know that these come in sizes. This is as important as your shoe size. I cannot tell you. When you book a session with me, I usually, if you're a full session, you absolutely must do a flange sizing with me, because I cannot tell you how many times it's the equivalent of someone who is a size 2 wearing a size 8. Like, it's really, really drastic. And if you are using the wrong flange size, there's just no way that you can actually be super successful or successful at all. Also, you might end up having terrible pain. You might end up with nipple damage. All of these things are related to flange size. So these have sizes. There are plenty of charts on the internet. There's plenty of measurement things that you can try to look at. If you need help, you can always come by, but these have sizes. A lot of times it says it directly on the flange. It says it like right on it, depending on the company of the flange. It says it in different places, but they have sizes, which is good to know. The next thing that you must know is you need to know how to work your pump. Whether you are pumping occasionally or exclusively pumping, I mean, this pump is like your lifeline. I mean, this is the way that you are emptying it. So many times I'll have moms come to me. This is my next best question. And it almost comes to a point, not almost, it has come to a point where I ask a question to moms and then I start smiling and I tell myself not to smile, but I'm almost excited to hear what it is that they're going to say because of the millions of different ways that I've seen on the internet and on Instagram about how to use your pump. So I'll just say like, okay, you turn your pump on and then what? And then like I hear this, who knows what I'll hear at that point. And then they look at me and they're like, and I'm like, you're fine. You're fine. Nothing you're telling me is shocking. Nothing you're telling me, but what it's showing me is that we are going over these settings no matter what. I need to make sure that you fully understand how to use this pump. If you're an exclusive pumper, for sure you need to know. But if you're a nursing mom and you're going to work, unfortunately, nursing moms in America end up pumping more times a day than nursing during the work week. And it's incredibly unfortunate. It's another cause of postpartum depression and anxiety that comes when moms go back to work. And one of the main reasons why moms stop pumping once they go back to work is because they have no freaking idea what they're doing with their pump. And they really hate their pump. They just hate doing it. They miss nursing their baby. They're like, what is this? They're usually stuck in a closet. They're stuck in a bathroom. They're stuck somewhere. They don't know what they're doing. They're possibly in pain. They're possibly getting no milk out when they know that their baby's able to empty them. The pump is clearly not emptying them. There's a lot of stuff going on there. So you need to know how to work your pump, okay? Last thing that you absolutely must know, on top of tons of other things that you need to know, but the last core foundation that you need to know is you need to understand your supply. You need to understand how it works. You need to understand how your baby is getting fed. Why do you need to understand your supply? Because your supply equals your baby eating, right? If you are undersupply, the average baby eats between 24 and 32 ounces in a day. I say average because my 1-year-old upstairs eats 35 ounces in a day, but babies eat between that amount usually. You need to know that you are providing enough milk for your baby. Now, when you're nursing, you're basically just using information such as, is your baby gaining weight? That's the biggest way that we understand if you have supply. Number 2, is your baby having wet or dirty diapers? Number 3, how concerned is your pediatrician? If your pediatrician, every time you go back there, is telling you that, you know, your baby's not gaining weight, something is going on, it could be a supply issue. It could be anything. It could be a supply issue. It could be a transfer issue, meaning your baby's ability to take the milk from your breast and put it into his or her body. It could be, or it could be supply. So you need to understand what's going on with that. If you're an oversupplier, you need to understand how to manage that. I am a massive oversupplier. Now at the point, when I had my daughter, I was making 90 ounces in a day. You guys understand what 90 ounces is? We say those Costco grape juice bottles that are 64 ounces. I was making 1.5 of those. Like, let's just think about that. That was insanity. And if for someone who doesn't understand how to manage that, now you do not need that. You should not do that. But I wanted it because I'm a professional. I was able to handle it. But that is pure insanity. And if you don't understand how to handle that, it is beyond overwhelming to deal with on a day-to-day basis, and to have clogs and to have freezers full and to have constantly having all this situation. It's so overwhelming. On the total flip side, you're dying to feed your baby breast milk and you cannot get enough in the bottle to give your baby what he or her needs. It is so stressful. And then you're forced to formula feed, which is, I promise you, I always say this, formula babies still go to Harvard. I promise. All formula babies are smart, are beautiful, are wonderful. My husband is formula fed and he is a fabulous guy. There are plenty of people, I'm sure, plenty of people on here were formula fed, and you could tell that you are top notch. So don't worry about it. But if you have a goal to breastfeed, then I want you to reach your goal. But you need to understand how to work your supply. You need to understand from the beginning, if you know that you're an oversupplier, that you're an undersupplier from a previous baby, you need to understand what to do. If you understand that you're an oversupplier from a previous baby, or you make just the right amount, which I made with my first son, you need to understand how to handle this. Oh my God, am I running out of time? Let me see. Okay, next slide, please. Here is where I want to just talk about the emotions of breastfeeding. People will ask me, so again, I want you guys to understand that when you're nursing, it's much more, I don't want to say difficult, but it's like much easier to be like, my baby's probably getting enough. Usually babies are, but like it's much easier to be like, my baby's fed. You know, sometimes your baby will go on your breast and they'll have 4 ounces, and sometimes they'll have 6 ounces, sometimes they'll have 1 ounce because they wanted a quick snack. When you are exclusively pumping or you are pumping at work, it is very obvious whether or not you need to supplement, because if you don't have enough in the bottle, then you need to supplement. It's very cut and dry. Your baby needs 6 ounces and you are making 3 ounces. You need to find food elsewhere and you need to supplement. Supplement could be either donor milk or formula, but you need to find some sort of supplementation for your baby. So if you are making, let's say you're pumping 10 or 15 ounces a day, people will ask me like, is this worth it? Should I do it? Should I stop? And I always say, breastfeed for as long as it makes you happy and as long as it brings you joy. If you're pumping 3 ounces in 24 hours, but you love it and you are so excited to go sit by the pump and you are so excited because every drop that goes into your baby is just so incredible and you're just so happy about it, then it is worth it for you because it is giving you joy. But if you were making 60 ounces a day, and I've had people make 60, 40, 50, but you are miserable, you should stop, girl. You should absolutely stop. There's no reason for you to be pumping any amount of ounces per day. If every time you sit down, you're like, I am miserable. I feel postpartum depression, anxiety creeping up my shoulders. Whether or not I do, I feel like I'm not living my life. My life isn't my own. My life is someone else's. And I am not enjoying this. If that is the case, I always tell you, if you can, come find me, come find someone that can help you, because a lot of times you are doing a lot more than you have to based on what you might see on the internet. Cannot even tell you the kinds of things that I see on the internet that you absolutely do not have to be doing, but you might be doing. So number one, just like make sure that you're actually doing what needs to be done. And then after that, do it for as long as it brings you joy. Because in life, and this is not only with breastfeeding, this is in your relationships, your friendships, your job, the cost has to meet the reward. Okay, the cost cannot be higher than the reward. The reward always needs to be higher. So if you are giving everything of yourself to exclusively pumping, and that means you're sitting there and you're pumping 6, 7, 8 times a day, but the reward is so high because your baby is getting breast milk, you are so happy, and the reward is high enough. But if you're sitting there and you're just giving too, the cost is just too high. And again, friendships, relationships, marriages, if you are giving too much of yourself in there and you're not getting enough of the reward, you have to reassess, and something needs to change. So that is always just like the objective way that I tell moms to decide whether or not they want to continue doing this, is to say whether or not it brings you joy. Thank you. That is, hold on. It took till the end, thank God. I'm sorry. So that is what I have to say about breastfeeding and pumping. And if you need any help, you can always find me on Instagram at One With The Pump. And yeah, thanks guys.
Okay, thank you so much to both Dr. Macaluso and Tamari. And thank you all for listening. We hope you're enjoying so far. Now it's all of your guys' turn to start asking questions in the Q&A box. So we're going to start with some that we got earlier. So these 2 questions kind of have like a similar theme of what to do in preparation for breastfeeding. So I'm going to read the 2 questions. So firstly, what can I do while pregnant to prepare for breastfeeding? And the second one, also very similar, is that I was unable to rescue my first child successfully and was incredibly disappointed. What can I do to then be successful the next time? So I can leave it up to Dr. Macaluso, Tamari, who would like to.
I can start if you want.
Okay, perfect. You both can answer also. That's perfect.
As Tamari mentioned during her talk, she had mentioned seeking help. And I think, especially when you have had an unsuccessful first experience, it's a large portion of the prenatal visits that I see in my office is women. It's so important to share that experience. Whenever you come in, one of the first questions I'll ask, if it's not your first baby, is please tell me boy, girl, age, and your previous breastfeeding experience, because it shapes your now. And it's so important to hear that. I think a lot of women, not only with their first, need to purge and share their birth story, pregnancy, everything they've done to get to this momentous point of finding me, but especially when you've had challenges breastfeeding the first time, they need to be shared. They need to be heard, and you need to get an evaluation. I think it's really helpful. A lot of patients say, even by reading and watching videos online, sometimes it's really hard to get latched down without someone being one-on-one, hands-on with you and help you to make it happen. So I think the most important thing would be to find someone, I'm hoping, find that person who can support you and be with you. And I think one of the other expressions I've learned in the postpartum fourth trimester and just what my practice is about is there's a therapeutic method known as holding a patient. It's really being present and actively listening and loving mom and baby and really being there for the patient. And this is a field of medicine where it's so essential to include that in the care that you provide, because you really have to make them recognize it's a safe space, that our goal is to help you to reach your goal, do everything we can within our power to evaluate both of you with loving, caring, time-intensive care and help you to make it happen. And obviously, you know, as Tamari nicely stated too, like it doesn't always happen for everyone. Everyone has their own breastfeeding journey, but I think the number one thing that's always that we deserve is to know that we were heard. We did everything we could to make this happen. We are thorough about the care. We are addressing mental and physical you know, effects and symptoms and doing everything we can to make this happen.
And Tamari, if you have anything to add or.
Everything I was going to say,
Okay.
me and the doc are totally on the same page.
I love it.
Perfect. So then we can move on to the next question. This is a little bit different. So one person asked, on the questionnaire I get at my kid's pediatrician's office, I feel like I'm not honest with my answers. How can we fix the system to not make new mothers feel shame by not being okay? And then whoever wants to take that question.
So fixing the system is something that I think we are trying to do in every aspect of life right now, in everything, which is, before talking about fixing the system, I want to talk about how I can help you specifically. And what I'm going to say is that the one thing I did right before I had my first son was that I had a conversation with my husband and I was like, I don't know how I'm going to feel. I don't know how this is going to happen. I don't know how this is going to go down, but I want to let you know because, you know, as women, sometimes we know, as men, they much less know because it's just not in what they talk about in their friends group. Postpartum depression and anxiety. And I just let him know about things to look out for. I said, I don't know how I'm going to be, but I need you as my supportive husband to be aware and watch me and look out for signs of postpartum depression and anxiety. And I cried a lot. I cried a ton. I always tell my moms who are like within the first 2 weeks, like, cry in the shower, you're going to cry on the bathroom floor, like you're going to cry, all you're going to do is cry. But there's a little bit, if you find yourself not answering the questions, that the answer is not, I believe it's like 0, meaning like if you are feeling alarmed about yourself, that's something that if you can't be honest with your doctor about it, at least can you try to be honest with your husband, your mother, your therapist, if you see one. Another thing, besides for getting prenatal care, you can also get, you can look for a therapist before. I'm not saying you have to start seeing a therapist beforehand. I love therapy. I've been going to therapy for years. But if you just want to like get the name of someone and even reach out to them and be like, I'm about to have a baby, just in case, you know, I want to talk things through. Do you have any openings? Just so you have the awareness of it. So again, I don't have any ideas about how to fix the system, but what I could tell you is to personally in yourself, look for people in your family, in your corner that can help you.
I think so too. And I think you could bring that person perhaps with you to a visit if you feel like they could be a good advocate for you and help you to express your feelings. A lot of times it is nice to have that support person there, your partner, your mom, a sister. Often I find I try really hard to include those people in the visits. It's just so helpful to have them be educated and have everyone be aware with what's happening.
Okay, thank you so much. And for the next question that someone asked, I guess like what is a proper feeding schedule? I know Tamari, you kind of touched upon that, so.
I can do the pumping if Dr. Macaluso, you want to do that. You start with it.
I'm all in. So,
over here.
Yeah. So the American Academy of Pediatrics actually just updated their policy statement 2 to 3 weeks ago, and the global really recommendation of feeding timing is 8 to 10 feeds a day. So we state 8 to 10 feeds in 24 hours, not exactly every 2 to 3 hours, because you really want to feed a baby what we call on demand when they show signs of early hunger cues. And those are typically licking and rooting and mouthing and clenching their fists. It's the best time to put a baby on. Crying is considered to be a late indicator of hunger. So the major goal is to have in your head somewhat memorized over the first month. It's about 8 to 10 feeds a day. In order to get to 8, that's like at least every 3 hours. So if you have a really sleepy baby, the recommendation would be to initiate the feed. You may have to wake your baby up, pull them out of a swaddle, get them on, stimulate them, tickle their feet, rub their backs, get them going. You really want to try hard to get that frequent stimulation going, because the number one way, I think I was reading through the question, so I'm going to hit on another one. The number one way to make more milk is to stimulate with nipple stimulation. Nipple stimulation causes your prolactin milk-making hormone to pulse release throughout your lactating experience. So you really want to try to keep your prolactin up by latching frequently, and or if your choice is to pump or latch isn't going well, you really want to use your baby or your pump with frequent stimulation. So no set timing, no set schedule. On demand is the recommendation. 8 to 10 times a day, give or take, for the first month. You want to watch your baby gain weight well, and then usually 1 month and beyond, they will on their own start to drive the car to every 2 to 3 hour feeds during the day and gradually extend the night span.
Come, sorry guys, we're about to have a visitor, but we made it through most of it. Come, Mama, come, it's okay. So the difference is with nursing, exactly, like the baby will let you know. With pumping, it is very different because you really can be on a set schedule. So people have options. You can decide if you want. It's okay, Ma, you can give it to me. You can decide if you want to feed exactly the same time. Should have put on her pretty pajamas. Sorry, guys.
You put these on, I didn't.
You can decide if you want to feed the baby, to pump the same time that you're feeding the baby. If you want to do that, that is totally up to you. You're welcome to. A lot of times people will tag team. They'll have their husband or their mom feed the baby while you're pumping. That's definitely an option. Option 2 is make sure that you are emptying your breasts every 3 hours. I really say every 2 to 4 hours, because, you know, if the baby is sleeping and it's been 2.5 hours, you should probably just pump there and then and not wait for like this to happen. And then you would have to pump. But like also on the other hand, if, you know, it's been 3 or 3.5 hours, it's fine. It's fine. It's been 3 or 3.5 hours and the baby is crying and like, you just can't pump, then you're going to have to pump at the 4 hour mark and you're going to be totally fine. And so is the baby. So about every 3 hours, but I like to do 2 to 4 to let you know that whatever you're doing is amazing and just do your best. As long as the baby's getting fed. That is totally independent of when the baby is feeding. The baby should be getting a bottle whenever the baby is hungry. We don't starve babies and we don't make babies wait till they're 3 hours. Got it, guys? Cool.
Okay, thank you. And then for the next question, so postpartum depression was like vaguely mentioned, but wasn't gone into detail about its effect on breastfeeding. So is there any effect? Can you elaborate on that? Wants to take this question?
I feel like we both have different perspectives, so I like that we both talk about it. I'll start just so she doesn't, just you never know.
Totally fine.
I think with me, I have a totally different perspective because I was very, very close to it with my first because of how disappointed and rejected I felt from him because he wouldn't nurse for me. So, and if I continued to try to nurse, I definitely would have gone to a point where I would have needed some sort of intervention. Like it was, you know, if you find that your breastfeeding journey is just putting you in the place of postpartum, it's so overwhelming and it's so defeating if it doesn't work. You know, what do you, Dr. Macaluso, what do you, I know you see obviously people for latching all the time, so what do you think about it?
I totally understand where you're coming from. And I do find not infrequently I'm in a position to help someone in their decision to move on. And I feel it's such an important piece of my world is to help that person to move on. And I think our job is to recognize when you're having these symptoms, hear you, love you, feel you, hear your goals and help you to reach them. And if that's helping you to reach them by utilizing therapy and or medications, then we're going to do everything we can to help you to feel good about being a mother aside from breastfeeding, and then recognize what your breastfeeding goals are. And yeah, I've had plenty of moms who are, it's not happening or it is happening and it's just, life is just way too overwhelming. And it's our goal to help hear you and support you in what you choose to do.
I did not nurse her one day. She only got a bottle and we are very bonded. So don't worry, guys.
So I guess along those lines, for the next question, someone asked about the formula shortage, that it's only making them more stressed about breastfeeding. And they said, like, what if I really do need supplementation? So I guess, Tamari, if you could elaborate a little bit on that. Like you said, that the bond is perfectly there and not much to worry about.
I promise you guys, I had to use formula with my first because I clearly, as you guys have heard, did not get off to the right foot. So my supply wasn't necessarily where it was. And then, you know, sometimes you'll have dips. If your period comes back, a lot of times you'll lose some supply. So I had to use formula, and he's totally fine. Like, he's really fine. It doesn't take away from the fact that what your brain thinks and what your heart thinks are two different things, you know. So I'll be like, he's fine, Tamari, he's fine, as I'm like, I'm giving my kid poison. Like, you're not. Like, what you need to do is you need to feed your baby. And I'm going to say something that, like, I say it to my clients all the time, but it's a little bit harsh, but I think it's really important to hear, because for people that do not want to give formula, I think it's really important for you to understand that it is more selfish of you to not supplement when your baby needs it, or it is more selfish of you to continue in a breastfeeding journey that is making you depressed because you don't want to give formula. Now, obviously, yes, we're in a formula shortage, so it's hard. So if your goal is to breastfeed, you should go for it, but don't continue to breastfeed if you don't want to, because you're nervous that formula is bad. And on the other point of it, thankfully, we're not at the end of it, but thankfully formula shortage is better than it was 3 weeks ago.
And you can always talk to your pediatrician if you're having a hard time finding formula. I mean, some kids do have medical indications with allergies of needing hypoallergenic formulas or amino acid based formulas, and you do have the ability to speak with your pediatrician who can help you to navigate that system as well.
I just remembered, I actually have a class that I did with Dr. Bridget Young of Baby Formula Expert. You guys should check her out. She's fabulous. It's called Navigating the Formula Shortage. And we went over all the different ways that how you can get through this, what kind of formulas you should be looking for, what to do if you cannot find the formula that you're looking for, at what point can you start using cow's milk or oat milk or any other kind of milk. You can check out, it's on my Teachable page, which you can find through my Instagram. You can always obviously email me if you need help finding it, but Dr. Bridget Young was fantastic. And she really just gave a lot of information about how to navigate this crazy formula shortage.
Okay. And then one more question. Can you discuss tongue and lip ties in relation to nursing?
That's totally not me, doctor. That's all you. I know nothing about tongue tie. I know what I'm good at. I'm going on mute.
That's a whole nother talk. so
Dr. Macaluso.
So that's really hard to put into one sentence, but I'll try to do it in a couple. So that can present with mom and baby symptoms. So you can present as a baby with difficulty with latch, prolonged feeds, dissatisfied, poor weight gain, having a hard time transferring milk. It's on your differential of a baby not gaining weight well, having a hard time with feeds. Moms can present with pain with latch, cracking, nipple trauma. They can present with plug ducts and mastitis because baby's having a hard time draining them and taking milk off. Whenever you see issues going on of moms having symptoms, babies having symptoms, you want to do a full evaluation of both. You want to really realize that there is more to the differential than just ties. You want to really, I've seen people come in, I have tongue tie and it's the baby is sleepy and that's causing similar symptoms. You can see moms that have hyperlactation or overproduction that present with similar symptoms. So I think one of the main things to be said is you really want to do an evaluation of both mom and baby. You want to make sure you're not missing other diagnoses that can present similarly to this. And you really want to see that that baby has restriction on exam of their lingual frenulum, that they can't move their tongue as well, and they are it's impacting feeds. And then obviously if all that's going on and they have restriction, you can consider referring them for a procedure to help release it.
Okay, thank you. And now for the last question. So is there any difference with feeding after a C-section?
So the recommendation there is feeding right away after a vaginal or a C-section delivery. So the goal is skin to skin and feeding in the golden hour immediately after delivery, rooming in the hospital and trying everything you can to get breastfeeding going right away. Obviously, when you have a section, you do have an incision. So when Tamari talked about the famous football hold, you find a lot of you are being taught to do that hold in the hospital after a C-section, because then the baby's off to your side and isn't on your incision area. But the recommendation with the section is still to try to breastfeed right away. You know, obviously it's nice to have a partner or other people helping you, because you are recovering from, you know, more surgery than a vaginal delivery is, but the recommendations aren't changing. The only thing I'd say is you're at a possible higher risk of a delay of what we call lactogenesis 2, of milk coming in, which is around day 3, 4, 5, usually for a first-time mom. We move on from the colostrum first milk phase to making more milk, and sometimes that can be a little delayed in the section. So, you know, you want to make sure that you're getting good care, that you know, a provider is paying attention to your baby's normal weight loss gain, and that we're paying attention to your milk coming in, and that you're both thriving and doing well.
Okay, thank you so much. And then before we sign off and end off this webinar, I want to ask each of you, both Dr. Macaluso and Tamari, to give one piece of advice to mothers whose goals are to breastfeed. You could take a few seconds to think. I know it's
I have an immediate one that just came to mind.
Oh, perfect.
Yeah, I like to call it that it's a definitive journey, and don't psych yourself out if it's not happening right away. It can still happen. There's so much that can evolve and change with time. I think it's really hard not to be instant gratification these days, and I think just COVID and society, it's so hard not to be anxious these days. And we're in the hospital, if you deliver in the hospital, and you're home so quickly that it's hard to get a lot of hands-on care in our system currently. I think it's really important to know that there is help out there, that you can get high quality hands-on help to help this to happen. And it is a journey, and things usually do get better. And then unfortunately, sometimes you master the first part of the journey, and then new things are going to keep coming up at you. The art of parenting is recognizing that we can't control everything that happens, but the more we can ask for help and get quality help and hands-on care, things can really progress and evolve. So try hard to be mindful and take deep breaths and think positive, and seek loving, holding care that you deserve. Surround yourself with the support I'm hoping that you can get from your partner, family, friends, and your community, and enjoy the journey.
Everything that you said, for sure, for sure. I think you could tell that you and I just see like so many moms all the time, because
Yeah.
these are the things that we see. And I think just totally to add on that, because everything that you said was totally accurate. It's just like to give yourself some grace and to cut yourself some slack. This mother thing. I had my mother-in-law come in from Lawrence tonight so that I wouldn't get bothered. And here we are, because kids, you know, you have to give yourself some grace. It's being a mom, being a new mom. Oh my God, being a new mom. But being a mom in general is so difficult. And then you put this huge pressure on yourself, which is breastfeeding, whatever method you're trying to do it in. And it's so stressful. And, you know, I'll always tell people, you know, you want to see a lactation consultant because you're having difficulty, and people are like, oh, I'll just see someone on day 5. And I'm like, that's like 45 feedings. That's like 45 times of sitting there distressed, not knowing what you're doing. It's really hard. Cut yourself some slack. And also, just in this day of social media, a really important thing that I really want to tell you is that, like, find 2 or 3 people that you connect with, and just listen to what they have to say. Like if you know, for people who go see you, Dr. Macaluso, like just listen to you. Like they don't have to go and then listen to like 300 other people that they see on Instagram. Like if you're saying it and you met with them, that means that you know what you're talking about and you're telling them. If someone is my client and you come to me and I give you advice and then your friend's sister's wife then tells you, like, cool, I'm happy that that's what she had to say, but like we had a conversation, I spoke to you about it. It's not even about like me being right versus them. Like it's about you as a mom, not knowing who to trust, not trusting yourself yet, because this is a new environment for you, and understanding that, you know, there's a lot of different opinions on there, and just go with who you trust, go with who feels right in your gut. And it really, like this part, it gets, I want to say it gets better. It gets harder, actually. The toddler part is much harder, but the breastfeeding part, once it gets easier, it really does get better. So just allow yourself to, as you said, also like just enjoy the journey the best you can. Right, Molly?
Okay, thank you.
Right.
Thank you so much to you both. Thank you everyone for coming. Please click the link from the chat box for the post-session survey and fill that out. This webinar will be uploaded to the JOWMA YouTube page this week, so stay tuned if you want to rewatch it, you want to share with anyone, you find it very helpful, feel free to do so. And thank you again, everyone, and keep your eyes and ears out for any future Women's Health Committee events in the next couple of months. Thank you so much, everyone, and have a good night.
Thanks. Bye.
Thank you.
Thank you so much, everyone.
Thank you so much.
And we'll be reaching out, asking maybe if you have a couple of online resources that we can be sending to all of our registrants that you find helpful.
Oh, this is still recording.
Yeah, that's okay. I'm gonna cut it.
Oh, okay, fine.
Perfect. That would be really helpful for everyone that registered. Just a couple of links. I know there's a couple of websites that I've personally looked into, but if you have any ideas, I'm going to reach out tonight. But really, thank you so much. I hope this was a good experience. I hope you learned.
Thank you so much.
Everything. This is wonderful.
Hey, you're welcome.
Also, people really enjoyed, so thank you.
Okay. It was nice to meet you guys, and nice to meet you, Tamari.
Nice
Nice to
meeting
meet
you.
you. I
too.
feel like I think I have heard of you before, so it's nice to meet you in person.
Yay, you too.
I literally just said in person, but this is in person these days, apparently, right?
I agree.
Nice to meet you via Zoom in person.
Yeah, I'm totally with you.
Good night, guys.
Good night.
Good one.
Night.
Bye.
Bye.